Okay, good evening, everybody. I think we will get started. We have a good number of people already joining, so out of respect for them, and more will join, I'm sure, as we go along. We have close to 20 people online. We at RNAO have been very involved in supporting the federal government initiative and, of course, also the Ontario government initiative of bringing Syrian refugees to our country and doing all we can to ensure that they are embraced and that they are given the opportunities and the support that are absolutely necessary for them to succeed. This fits, of course, with RNAO's ends from the board, which is both speaking out on emerging issues, which is end number 3, and of course the tragedy in Syria is of massive proportions, and the millions of people that have been displaced require our urgent attention. Also, of course, with RNAO influencing healthy public policy and advancing the role of nurses in the process. Doing so, we have dealt also with number 1 on engaging parents, nurse practitioners, and nursing students to ensure that they serve the public and that they are fully engaged in the process. We have done several initiatives from RNAO. We contacted Access Alliance Multicultural Health and Community Services upon their request and asked for RNs and NPs that were fluent in Arabic who, if they were interested and able to volunteer so that they could serve people in one of the 5 hotels that are housing Syrian refugees. We receive a very generous response, and those people are being engaged through Access Alliance. We also, you can look in the latest RNAO journal in a column that I wrote about this, plus the cover feature that is in the RNJ, that we also have done other initiatives like work with the Ontario Medical Association in putting together a joint press release so that we could shift public opinion, which several months ago, if you remember, was a bit split and not all on site as we should have been. And I think that the fact that we did these initiatives did help shifting public opinion and being much more open arms as we should be. We are today starting the first webinar. These webinars are on March 8th from 21, March 21, 5:30 to 6:30, and April 21, 5:30 to 6:30. And we very much appreciate the support of colleagues that have offered to support this educational endeavor, starting today with Christopher Bradley, who is a nurse practitioner, and he will introduce briefly himself. And the colleagues that have offered to support this educational initiative, just so you know, are colleagues that have direct experience in working with refugee health. So rather than opening for questions now, I will pass the mic, so to speak, to my colleague, Chris Bradley, to introduce himself and to proceed with the educational piece. Thanks very much.
Okay, Doris, and thank you everybody for coming during dinner time to this webinar. So my name is Bradley, and I'm a nurse practitioner working in Ottawa, and working with refugees since about 2008. Today is kind of a suspicious day because the federal government announced the reversal of the cuts to the interim federal. A long battle, so that's fantastic. I work in a community health center, so we end up seeing a lot of uninsured patients, which includes a lot of refugee claimants. And recently I've gotten involved supporting Syrian refugees, government-assisted refugees at some of the hotel sites that are happening in Ottawa. Recently, 4 interim lodging sites, and I go into one of them with a colleague 3 afternoons each week, probably 100 to 200 people, Syrian, at any given time in that hotel, so it's a pretty busy clinic. So, quickly start with just a few stories just to kind of contextualize all this stuff that we're doing and why we're doing it. This is just a composite, it's not exact patients, but I was seeing a new patient. He was a privately sponsored Syrian refugee, early 40s, with a chest pain. And I was asking him if there was any family history of cardiac disease. And he looked at his sister, who was in her 30s, and I could tell something had happened. So it turns out that they were told that their father had had a heart attack. But the actual story was he had been taken off the street, detained, and disappeared for 20 years. And eventually learned that he had been in some kind of prison within Syria, and that they say that he had a heart attack, but who knows what happened to them. The sister was in tears, and you could tell it was still raw, like she was obviously a teenager when this happened. And just exploring things a little bit, it turns out that, there's a checkpoint on every corner in the cities in Syria, and this fellow had been detained himself for 8 hours, but you can imagine the stress that would have caused, and just the ongoing trauma that would lead to. Another family that I'm seeing, they're actually Syrian refugees who are rejected claimants. It's hard to imagine being a rejected claimant, but it's with 2 children, and the dad wakes in the night screaming. They fled to Lebanon, and the dad was threatened by Hezbollah. The kids go to school because they were teased because of their accent, their Syrian accent. They were called Daesh or ISIS. So to school, and when they ended up in Canada, the girl had a strabismus. They went to an optometrist. Because of their status, the optometrist didn't realize they were covered. He asked the family for their eye exam, and then he didn't refer her to an ophthalmologist. He told them, wait till you have OHIP if you ever get it. Long story short, she was actually insured. However, the provider didn't understand the differences in coverage and so on. So it just kind of behooves us to be up to date on who's covered for what and what the benefits are and so on, so we can support our patients. So we'll go to the slide.
So I'm experiencing some technical difficulties on my end, but I'm trying to fix that. If you continue,
Sure. Okay. So this presentation, it was called Ingredients for Success. So here's some just different ingredients that kind of came to mind as I was thinking. So that essentially we just have no idea what people have been through. So it's hard, obviously, not to objectify or stereotype people. The word refugee is obviously kind of a social and political term, but it really tells us a lot about who these people were individually and as families. So keep in mind, what I put up there was know your resources. If you're seeing a patient and you really want them to see the dentist, it doesn't go far enough to just say you have coverage, go see a dentist. It really helps if you actually have the name of a dentist who accepts IFH and speaks Arabic. If you have that, it goes a long way to helping that person get to the service. Yourself in other people's shoes, doing some advocacy, obviously. Small little bits of advocacy go a long way, like providing a letter or phoning the pharmacy on somebody's behalf to find out why they were charged for something. Someone's safe. That kind of means believing my patients in the way that I think of people who are in pain and not questioning if they're in pain, I believe what they say, or if it's somebody reporting some kind of abuse, that I start off with belief. I kind of apply that to my refugee claimant patients as well, or even my GAR patients, just if there's something, I'm believing it. It's not up to me to be the judge or that kind of thing. The thing is working as a team. Obviously, we can't do everything ourselves. built a network of people around me that I can call up and ask my quick questions. So they're my experts, like my settlement counselor, my caseworker, social worker, lawyer. So I've got like kind of a person in each of those pots, and I can phone them up with my really quick question, which helps a lot. And the final point to this was that just to enjoy this work, it's really fulfilling. It's very meaningful. And I wanted to kind of do international health, and I'm in Ottawa. It's not international, but every single day I'm just meeting really interesting people with fascinating stories. So it's quite fun. The next slide, but the slides aren't working.
Please.
Oh, sorry. I guess I'm the host of this event now. Sorry.
Right?
Oh, is that right? Okay, mine's not advancing. That's fine. That's fine. In terms of the numbers, see, I'm just going to have to toggle between a moment. Okay, so in 2014, Canada took in about 23,000 refugees, about 9% of the total number of newcomers that came to Canada. So it's not a huge proportion. 7,500 were government assisted, about 7,700 were refugee claimants, 4,500 were privately sponsored. So February 9th, about close to 18,000 Syrian refugees had arrived, and there's going to be another 8,000 or so arriving by the end of February. So this is basically double all the refugees we accepted in 2014, with a lot of refugees. Like, on to the next slide. Putting these numbers in context, you can see that these countries, which are less well off than Canada in many cases, have taken on similar numbers of refugees. We're not taking really that many when you put it beside Turkey or Lebanon. Going to be like the United States, obviously. They've taken in 2,700, which is not. I just want to explain what a GAR, PSR, and claimant are. So a government-assisted refugees, shorthand is GAR, that are UNHCR refugees. They've been identified by the UN overseas, and Canada agrees to bring them over and to support them for the first year with income support, health supports, and so on. They get a government assistance caseworker who helps them kind of negotiate systems within Canada, like getting a bank account, finding housing, and so on. The privately sponsored refugees, or PSRs, sponsored by groups like church groups and different civil society organizations, whatever, groups of 5. And the groups are usually responsible for paying for the income support and housing support for those refugees for the first year. The health stuff comes from the government. And the Syrian refugees, the privately sponsored refugees, are receiving income support. Sorry, wait a second. They're getting the health support. Sorry, I don't think they're getting the income support. And refugee claimants are people that come to Canada and they make a refugee claim either at the airport or once they've been here. Let's see here. See, there's going to be challenges with this number of newcomers all coming at once. It is called our Syrian Friends. Sorry, I just have to look at my other slide here. So the average family size is 5 or 6. It actually even be a little bit bigger for the GARs. The PSRs tends to be a little bit smaller size of families. 60% are actually under age 14. Who have a varied education and life skills. I'm finding that the GARs are a little bit less educated. A lot of times women didn't complete secondary school and haven't worked. And there's varying degrees of life skills. I do have some patients that like optometrists, denturists, and so on. To 90% don't speak any English or French. There's really a wide variety of different people in Syria, including Sunni, Kurd, Druze, Shia, Christian, Palestinian, and so on. Obviously, keeping in mind that people may be missing family members from back home. Also, let's see, a lot of, there's couples where there's the man is like 10 or 15 years older than the female partner. And that a lot of people had like a very normal life in Syria before the war broke out. Okay, the stages of resettlement. I wanted to point out that a lot of times when refugees arrive, initially there's a lot of happiness and hope and excitement and so on. Everything's new. But oftentimes after several months, you find that people are struggling and having a difficult time and finding that it's not exactly what they expected. And, there's disappointment. And sometimes people feel depressed at that point. So it's keeping that in the back of your mind because people often go through these different stages and, that it impacts. Like sometimes I don't necessarily diagnose mental health concerns at certain stages because I just know that there's this trajectory. We need to give things a little bit of time. Maybe there's just a lot of stress and change happening right now. Maybe this isn't the best time to address that particular issue. So it's just something to keep in mind. The next is called Just a Few Challenges. Obviously, I'm just going down to that. Like language, one of the rejected claimant patients have to check in with Canadian Border Services once each week, so it's hard to get a job when you've got to check in with the government every week. Income disparity is a huge one. I think that initially people are probably happy that they're getting some income and housing and so on, but they end up being the most poor of the poor in Canada, and they see people around them. They don't have money for phones, for example, and the expectation is that they'll go to their neighbor's house to use the phone. Gender roles is a big one. That oftentimes women learn language a little bit quicker than the adult males, and so it's kind of interesting. And during an encounter, you're talking more to the female than to the male, and that may not be the traditional gender role and stuff. It's children, so that's kind of interesting as well. When it was like minus 40 degrees here all weekend, there was like 20 inches of snow or something, so that's a total change. Kids are already skating on the Rideau Canal near the hotel where we're working. When getting kids settled in school, a lot of people are going to be a few years behind. A lot of the kids in Syria and the host countries like Lebanon and Jordan and stuff were not in school. So there was a kid from one ethnic group came up to one of the Syrian kids and punched him right on the face just out of the blue for no reason, for presumably being from a different religious background. And the other was just livid, and he kind of wanted to take justice into his own hands. And the whole thing just was like, wow, like I guess they're not, in some way, like the dad wasn't used to kind of like being able to rely on police and principals and that kind of thing. Obviously really different in Canada. Security issue when people like the only affordable housing, well, there's not a lot of affordable housing, but what we'll call affordable housing happens to be on the street where all of the drug and so on live, and where there's shootings and so on. In Ottawa, that's the case. So it's hard moving into a building with your family, and there's not a lot of security sometimes. Some of the Syrian backgrounder things, there's been some kind of pointing out that poor procurement is common in Syria, and it wouldn't be surprising for a parent to slap their kid on the face rather than the bum, which would not be acceptable in Canada. So that's obviously a concern for education and stuff. Housing is very expensive, and a lot of the privately sponsored, unless sponsors are really savvy, they may go into housing initially that's a little bit more than they're going to have the ability to spend on in 1 year, so they may be having to pick up and move in 1 year. Racism is always an issue, unfortunately. So moving to the next slide. Multiple require a team approach. In the Community Health Center, we have some fantastic people. Like there's system navigators, there's multicultural system navigators, or like peer outreach workers. There's Families First program, which builds a lot of support around families, and there's an earlier center for parenting support, housing worker. I've got a friend who's a teacher and an infectious disease specialist. There's income specialists at different places, and I would really encourage people to refer and to involve different people, because it really does take a team approach to support people with multiple needs. Sorry, my slides, I'm sorry, I'm just a little out here, one moment. assistance program. So this such income a family of four can expect $1,350 to $1,450 a month. I think the average rent for a bedroom in Ottawa is close to $1,400. I know that for a single bachelor place is like $780, which is essentially all of the RAP income for a single person. RAP is food incidentals. There's pay market rent. Once people are off the resettlement assistance program after 1 year, they get just less from Ontario Works, which is unfortunate because that's not a lot of money. Okay, next slide. Picture of Vancouver. GARs spend about 56% of their income on housing. Over 30% is when people are living in a precarious situation. I think people in Vancouver are literally paying, like renters are paying like a lot more than 30% for their income, and obviously it's a problem for the city. So that's GARs are living. So that's pretty difficult. And next slide. I think it's poverty.
Yes.
Yeah. Single most important factor which determines whether someone is healthy or not, and income is a modifiable risk factor. So poverty affects people throughout the lifespan, and social disadvantage places people on fairly predictable trajectories. So about that as nurses and nurse practitioners. We'll go to the slide. So one thing the most of people's benefits, the that you get through the interim federal health program are there for just for 1 year. As soon as people land, they get their IFH paper at the airport. That's for the GARs and the new privately sponsored refugees from Syria. So super briefly, I asked Josephine to attach a whole bunch of handouts to people. Some of them go into these in a bit of detail, but medications are covered through the interim federal health program. It's the same medications that are covered on the Ontario benefit formulary, but there's also a 2-page addendum of IFH meds, and it's basically vitamins, vitamin D, calcium, prenatal vitamins. Those things aren't on the ODB. It includes vaccines, so things like hepatitis B vaccines for adults, hepatitis A for men who have sex with men, and includes some anti-parasitic medications. And that's super briefly, all children who are low income qualify for dental benefits through the Healthy Smiles Ontario, and need a little bit of help filling out the form. In Ottawa, dental hygienists come to each of the community health centers, and any of the refugees can come and they can get signed up, and they'll help them mail in the forms so the kids have benefits. The adults have basic benefits for dental. If they have like something kind of urgent, they can get an assessment, x-rays, filling extractions. That's it. So there's some Ottawa-centric details about dental, and feel free to take what I've created, and you can just change it and make it relevant to your local place if that's helpful. Optometry benefits are covered in the first year, including glasses. After the first year, some people can still have optometry assessments with their card, like if they're under 19 or over 65, but the glasses are no longer free after that first year. So it's good to get people plugged in that first year, especially children, to get assessed. Physiotherapy is covered. You just refer your patient to a physiotherapist. As long as they accept IFH, you send it with the IFH paper. They'll do the predetermination. They'll call the patient to do the physio. There's up to 12 visits. Audio, the full price of hearing aids is covered, which is great because after that first year, the full price of hearing aids is not covered for people. There's some assistance through the provincial government, but it's only like $500 per year hearing aid. So it's important to kind of get on these things early if possible. The next slide. It's just a illustration in the middle of my. It's a Syrian proverb, and I'm not totally sure what it means, but it is nice. Okay, we'll go. A lot of children are not vaccinated. The records are in Arabic. In Ottawa, unfortunately, public health is no longer able to translate our vaccine records, so it's a challenge with that. Dentists are huge in this population. Like I really think that every single patient I've seen has like severe caries, and getting people plugged into dental early, I think, is a really good idea. Treat abscesses already. the issues that somebody brought up to me is like, we talk about the Syrian refugees have some support for clinical psychology, but part of the other thing is a lot of people have sustained injuries, like post-concussive things from injuries or bomb blasts and so on. In times of war, there can be problems with attachment between parent and child, so keeping that in mind in screening. Screening is really important, and like there's, I'll to that in a minute. New screening. I get to say it now. I feel like this population, the GAR population, there are really some issues with health literacy, and I feel like I'm seeing the impact of war written on this population. Just in terms of the health literacy, like for example, I was seeing an 18-month-old had not been introduced to solids yesterday. I was really surprised, but just breastfed. Has not eaten anything but bananas in the last month, bananas and water. There's people that are, one thing is ask about medications. I'm finding that people have brought medications from overseas. Obviously, they weren't sure what they were going to land and receive here. They didn't know that our system is the way it is, but people have brought all kinds of medications, including a lot of antibiotics. I was seeing a 4-year-old on the weekend. His dad injected him with ceftriaxone, 500 milligrams IM for fever twice. And other people have shared their antibiotics. So that's a question that I didn't used to ask people. Now I ask everybody, are you taking antibiotics right now? And do you have medications that you brought from Syria? Can you show them to me? And we negotiate and talk about that. Contraception is a big one. Is an issue. Let's see here. Infection and chronic disease. There's a good document it's in the handouts that Josephine can share with everyone. It's from the Ministry of Health and Long-Term Care. It's called Syrian Early Assessment Considerations for Primary Care Providers. To a fair bit of detail about all the different medical screening, like things for hepatitis B, different medical issues. It's really quite useful. Some really good guidelines that have been developed. Caring for Kids New to Canada, it's the Canadian Pediatric Society, and it's a guide for people working in immigrant and refugee health with children. It's one of the best websites I've ever seen for refugee health. It just has so much useful information with links. It's good for cultural considerations and cultural safety and competence and stuff. So I would urge people to look on that. And there's also guidelines about working with refugees there. Finally, there's the refugee screening guidelines that were put out, and you can find them in the Canadian Medical Association Journal. Okay, we'll go. More ingredients to working with refugees and Syrian refugees. So it's just important to make sure that people feel like there's a caring professional receiving them and welcoming them. Part of that for me is sometimes making it explicit that, your health, I'm not doing this for the government. This isn't to check off some list for someone else. This is really for you, and it's also confidential. And I let people establish the that they have. Form handoffs, I find, are very important working with vulnerable people in general, but especially with refugees. A lot of times I want to refer people to a counselor or to the prenatal classes and so on, but people often don't go, they don't show up. But it's a real difference if I take somebody down the hall and introduce them to the person that I'd like to refer them to, and just kind of establish that this person is safe, they're a friendly person, they're smiling, and that kind of thing goes a long, long ways, and I find the uptake for services a lot better that way. Sponsors and wrap caseworkers all the time. So whenever I'm meeting a new refugee, I ask who their connecting person is, and I ask if it's okay if I speak with them about certain issues. I'll establish that each time on the file, and end up contacting those people lots and getting them to help me for optometry, dental, or whatever it is. It just means if it's reasonable to go this far for a patient. Sometimes I just stretch a little bit further for refugee patients because who people have been through, and just going that extra bit sometimes just makes the difference for people. I use images all day long in my practice. Nobody, like, it would be me if I take my car into the shop and somebody tells me that my differential is out of whack, or I have no clue what they're telling me. And I'm pretty sure that it's the same thing when I'm talking about internal organs and all kinds of like tympanic membranes and so on. I use a lot. Advocacy, with patients, so making sure that people feel like they're heard and that they get a say in the outcomes and what's being tested and so on. That the times the parent has come in, it's been really hard for them to get across the city and use 2 bus tickets to come and see me. And other kid happens to be a little bit sick with a cold as well. Being available for me means doing to I can help in that moment. And also like returning phone calls and being prompt and that kind of thing. I find it does help me with my patients. And really, like I'm learning as I go. I'm just one NP and one nurse out of like hundreds of people that are doing such fantastic work with refugees. And so only just one perspective, but there's so much to learn from our colleagues. My last slide, system level advocacy. There's things that it would be possible to address, affordable housing, adding medications to the formularies, and so on. I guess just this whole thing about the FH for refugee claimants is just so unbelievable. Like the government took away benefits for all refugees initially, and they just put them back for the government-assisted refugees, but they were missing for the claimants, including children and pregnant women and so on. Finally, after so much work and lots of nurses were involved, the whole thing has been reversed and everybody is going to be covered as of April 1st, which is just fantastic. I know I was a really strong supporter of that, so that was great.
So to share, Chris, for those that are attending, RNAO was the organization, quite frankly, in the country, we requested and secured representation status on the refugee claimant issue against then Prime Minister Harper. So we were going to participate in the court case, and of course, Trudeau right away when he was elected said that they were looking into that. They restored part of it, and today they did full restoration of the program. But we went, just so you know, Chris, I'm not sure that you know, we went together with the Association of Community Health Centers of Canada.
Yes, I did actually, and I really appreciate like the strong voice. Like it took courage to step out like that, and it's just fantastic. Like I just felt really proud as a nurse that RNAO and CNA and different groups were standing up, but RNAO did a fantastic job. I'm done with my presentation.
Let's open for questions. I think you did a fantastic sharing of your experience, and I think your point that we go, we learn both from colleagues, we learn from the people that have the lived experience. I think they're the ones that teach us the most at the end of the day, and to be non-judgmental and really to understand from perspectives and from where they're coming, because it's easy to say, well, now they have it better, but we need to make sure that they indeed do.
Yeah.
So maybe let's open for questions. Josephine, if you can guide us through questions and tell people how to send questions, perhaps.
Sure. So our teleconference line is open. You can feel free to speak on the line, or you can submit your comments in the chat box inside the webinar. It should be on the right of your screen, and I can read it out for you on the line if you'd like.
And both if you have questions, but also if you have experiences that you can share, we will welcome those too.
Mm-hmm.
How many
since 2008.
So that's good number of years. That gives you really a good perspective. Yes, we have some questions.
Okay, so our first question is, how could nursing students get involved?
First of all, learning and opening doors, whether it is within the health system as you do placements, but also in own communities. Let's remember that people that come from other countries as refugees or refugee claimants, both, which are different situations, that they need assistance not only with health care and health services, but they need also embracing at the community level and within our communities, so that they don't feel lesser and they don't feel less important, than that we can provide both an open. So I think that that's a very important piece. Then if there are students that know Arabic, in the case of refugees from Syria, we would love to, because there is a lot of need for translation, and we certainly can offer that to healthcare that need that type of support. They connect with Josephine, for those of you that are fluent in Arabic. Our experience with the Health Access Alliance is that they actually will first utilize people fluent in the language, because that's the shortage that they have at this point. I don't know, Chris, if you want to add anything, by all means. I'm speaking with our own friends and colleagues, right? I don't want to diminish the last point that Chris had on his list, which is racism. There is, I think, a great deal of racism still, and these people experience that. So I think it's very, very important that you demystify refugees, refugee newcomers. They be treated as everybody else with equal opportunities.
I would just say, just nurture interest in refugee health and newcomer health, because it's just so interesting. And at the University of Ottawa, they've got this amazing kind of program underway for medical students, where they'll team up with a family of newcomers, and they'll help them get the place to buy their bus pass, or they'll help them with some school issue. So they're basically looking at those determinants of health, which help people be healthy, not just the medical side. And I think that as nurses, that's something that we really excel at as well, is looking at the determinants of health and supporting people in that domain. And I find that in the workplace, a lot of times people are so busy that they've had time to find out who is the local Arabic-speaking pharmacist. And that's a difference, because it makes a difference between people maybe understanding why they're using a medication, how to use it or not. So I think that lots of place for nursing students to do some of the legwork to find out resources for people, and you could definitely support preceptors and future colleagues and stuff with that kind of information.
The question we've received is, I just posted a webinar, so I'll read it out. Great presentation. I'm wondering what kind of assistance is available in terms of trauma care. Have you come across any situations of individuals who have experienced human trafficking before coming to Canada? And the last question within that submission, what kind of resources are available for individuals who have gone through these kinds of situations?
We'll give it a try from your end, and then I can...
Too. You know what, you guys, this is where I fall down a bit. To be honest, I don't recall ever having a patient that I know was a victim of human trafficking.
I mean, I've had, not, especially not if we are talking about refugees from Syria. That will be, I mean, naturally, I don't think that will be something that you will see a lot. I wonder if the question has seen that, because
violence and that kind of thing. And I think that a lot of unfortunately young women, for various reasons, have been married to older guys for, like I say, for protection or for the family or whatever the reason is. But I'm sure there's issues with that. I've definitely seen people who have experienced a lot of sexual violence and trauma and that kind of thing.
Yeah, I know, even from the media, right, in terms of also not not only in terms of marrying with older people, which usually is for money because the family will get money. Also, actually, that's also from the perpetrators that come to those villages, right?
Yeah.
A lot of there's a lot of rape. I think that's a bit different than human trafficking.
Yeah, find that, like, I just in Ottawa, like I know that the resource for me that I use, there's two. One is the Ottawa Community Immigrant Services, and there's like people with different racial backgrounds who are trained in counseling that will see these patients, and I find that they do a very, very good job connecting with the patients and supporting. And also an organization called Immigrant Women's Services of Ottawa, and they'll have peers trained in counseling, and they do a very, very good job as well. We don't have a center for victims of torture in the city, unfortunately, but I usually end up referring people to those two places for counseling, and then I end up seeing people, but it's challenging for me for sure. Like I try and be available, but I also try not to re-traumatize by peers like lifting the Band-Aid off too early and so on, and it's a really hard one to know how to get right. I'm wondering if anyone else on the webinar has some experience with that they could share.
So a lot at the issue of PTSD. Anyone else has something to add to the conversation?
Part of the same conversation, someone else poses the question that when refugees coming from some of the war-torn areas in Central and East Africa, rape was a common weapon of war. Are you finding that to be the case with the Syrian refugees?
I have no doubt that rape is a part of probably every war situation, sadly, and it would not surprise me at all. But the early days in terms of with these interning sites and the clinics that we're doing there, and if you look at the guidelines to working with the adult refugees, there's advice about not necessarily asking right away. And it's my sense as well that it's not the appropriate time or space to ask unless somebody is. Sometimes it's obvious and it's clear, and you need to be. That's like the central issue, and you sort that, and that's the case. A patient of mine from Central Africa that I'm working with just right now, but in the case of the Syrians, nobody is presented and said like, this is an honor, obviously devastated. A lot, like the guards are usually arriving as part of families, so there's people together for one thing for families, and it's just seeing them I'm just basically offering an acute care service at the hotels, and for the sponsored and some of the claimants that I have, I'm working with them on different years and stuff like that. I'm getting to know them more as their primary care provider. I haven't had anyone that's disclosed rape. I've just had families with the couples and stuff, and my sense is that the families were supporting it in general. I'm expecting that there will be situations of this for sure.
I think, Chris, part of it is that they present it as their first top priority because they already went through the trauma. So some have even normalized the trauma. As they move along with their lives, they may need those type of supports if indeed they experience any type of sexual violence.
Or at different places along the way is important, like asking people if they feel safe, where they're living and in their home. Does anyone make them feel unsafe, and that kind of thing. The question is not as direct as were you a victim of sexual violence. Like it just depends on how things are going in your relationship. It's kind of an intuitive process for me, but
more gentle and less intrusive. And naturally likely much easier for them to discuss?
I think so.
Yeah. Yeah. I'd like to talk a bit more about the issue of the dental care because I've spoken with several of the clinics, and is something that really is quite serious to the point that sometimes it impedes proper nutrition. Can you comment on that a bit?
Yeah, totally agree. Like, I feel like Syria was kind of a low middle income country, and had just enough money probably to have some sugary pop kind of drinks, and obviously haven't had access to dental care. And I was talking to a mom that was feeding her baby some bread with milk and bringing in white sugar into it as well. So, and then people with the dental issues oftentimes don't necessarily want to address it because they don't want to have teeth pulled and stuff, and they don't know what to expect in terms of being able to get services and stuff. So it's definitely a big issue. I think that it's fair to ask, like, are you brushing your teeth today, and are you using toothpaste, and I think that's a fair question.
Thanks. The next question is directed to you. This participant missed the beginning of the webinar, so she's asking, what type of agency do you work with? Does your clinic have a formal alliance with the local cross-cultural center, or do you see such a refugee population just because of your catchment area?
Mm-hmm. We work at a community health center, and so one of the things about community health centers is everyone's on salary, and a big part of our mandate is seeing people who are insured. As a result, we end up seeing a lot of the refugee claimants because for the last 3 or 4 years, they really haven't had very good benefits or health coverage. It's kind of like that works. But the community health centers tend to be, there's multiple disciplines working there, including things like in our center, there's like a Somali youth program, there's Pathways Education, there's the Multicultural Seniors Lunch Program, and so on. So there's expertise, and there's a lot more diversity in my workplace than you would find in the Ottawa kind of working population. So we're not a cross-cultural center per se, but there's like a lot of expertise working cross-culturally in community health centers.
Where do you access translation services when needed?
That's a question because that's so important. So at the Community Health Center, we're so fortunate, but the Association of Ontario Community Health Centers has kind of brokered a deal, Access Alliance, I think, with Language Line. That's the RNAO network. And so what happens is I'll phone the interpreter, and usually I'm able to get an interpreter within a few minutes. And I think they charge about $1.53 per minute. And the service is really good. It's very professional. We use in-person interpreters from a different organization, but they charged a minimum of 2 hours per counter. And so you might see a patient for half an hour, or the patient might not show up, and you're ending up paying quite a lot of money for the interpreter. So the is a fantastic service. And IFH unfortunately doesn't have very much coverage for interpretation. It's not available for people very easily. So definitely seeing if you can connect to a patient through the language line, or the RNAO network it's called, RIO. That's a fantastic service. Also, just keep groups usually have somebody on their sponsoring team that will speak some Arabic. So being able to contact that. Also, patients all the time, like, can we phone a speaking friend? And then I'll ask, the first thing is like, are you okay if we speak about medical things with your friend interpreting? To do that, like, I don't have to do it language very often, but once in a while that kind of thing comes up. And translate, but I don't rely on that for medical encounters. It's just for the most basic thing that I need to get across.
Great. So I think that we have about 10 minutes left in the webinar. Any further submissions online. So again, just a reminder, you can feel free to speak on the telephone or just keep sending your great questions and comments online.
It's Sandra Kiyoki here. Thank you so much for the presentation. It was wonderful, and it's good to hear your voice again.
Yes.
I'm curious as to your women who are pregnant and when they're ready for delivery, how are they accept our Canadian system of mobilization and delivery?
I've got two newly arrived Syrian refugee GAR women who are pregnant. My sense is that they're both quite happy to be connected to physicians, but it's interesting because one of them is like a G13, and she delivered her last baby by herself at in her apartment or something like that, and she doesn't seem too stressed by anything. It's pretty funny. She's pretty far along in the pregnancy as well, but the other is happy to have it. I feel like I was saying, like the health literacy is not so great, but I think that people do have a respect for medical providers, and they appreciate medical care, and they're willing to kind of and all of that kind of stuff. I haven't had any sense that people are not trusting of the system. It's just that I feel like people don't have a sense of what to expect and that kind of thing. So my brief experience with a couple of prenatal GARs from Syria. What about yourself, Sandra?
Well, I experience in refugee. How interested in your presentation. But do you have a midwife in your community health center? We
have a connection to midwives if we want to refer to midwives. And for the refugee claimants, that was a fantastic option because refugee claimants for a while didn't have coverage for hospital care and OB services and so on. So that was a really great option for people that didn't have benefits. It's a great option for other people as well. I think people would be a little bit surprised if anybody was like requesting a midwife rather than having an OB. But you know, it's early days for me to know at this point. Yeah. I'm noticing that in this population, there's more sensitivity around kind of gender concordance, and I think that women really appreciate having a female provider. Like, people are respectful of me and that kind of thing. But even with the children, I find that, you know, the crazy about me checking the little girl's bum or something like that if she's got like a diaper rash and stuff, and use a rectal thermometer in a really sick kid wasn't acceptable to a couple parents. So being really sensitive around that. Really good colleagues, and I have a nurse practitioner student with me, and other women are more comfortable if she does the exam of like any private parts and stuff. So that's interesting. That's just something that I'm sussing out. Some women were fine and some women weren't, but I would say more so in this population than across the board, because most of the time I find women are pretty accepting, and they have an option. They're fine with me doing that. But in the case of the Syrians, the sense of it is that there's definitely some kind of modesty issues.
Mm-hmm.
Excellent questions, Josephine?
No further questions online.
So let me just share again a big thank you for Chris and for all of you that participated, and let you know that the next webinar is March 8th from 12 to 1, March 8th from 12 to 1, and the presenter will be Chantal Solm, and the primary care RN Center for Health Communities. So I think it will be a very good presentation again, relationship to a different experience. I'm sure there will be many commonalities, and that's what is so good of the different members that have expertise, that have agreed and offer so generously to step forward with presentations, that we will start to see some commonalities and yet some new learnings from the different colleagues and the different centers, and start Towich, the Director of Health and Nursing Policy, will be introducing that, and we will update our slides to actually include all the initiatives that RNAO has been involved, which you can read in the last issue of the journal, which is posted on the website, but you should have a copy. Because many, many initiatives that we are involved, and if you would like to get involved in some of those, by all means. Otherwise, we look forward to seeing some of you back at the next seminar on March 8th from 12 to 1. Let me just check with Josephine if we have additional questions. The materials will be posted on the website so that you can both access the PowerPoints and as well as the materials that Chris referred to. And again, Chris, a million thanks.
Oh, you're welcome. And also, if anybody does have further questions and wants to contact me, my email address is in the last slide.
Very much.
You're welcome.
And thank you.
Yeah. Okay.